the session. All right? Okay, now this is a case, okay? A 55-year-old man presents with the complaints of feeling like the room is spinning, feeling of dizziness, okay? Decreased hearing, and also ringing in the ears, which is called tinnitus. All right? All these symptoms have been occurring episodically, which means sometimes they are there and sometimes they are not there. Okay? Now on examination, okay, and on history, you find out that this patient is not taking any medication. There is no recent history of any trauma. Okay. On examination, you found that there is low frequency hearing loss. All right, and there is nothing else in the examination. So basically, complaint of hearing loss, feeling of dizziness, feeling like room is spinning. Okay, these symptoms are off and on. On examination, you find that there is low frequency hearing loss. Okay, so with your prior knowledge about the structure and function of the ear, okay, where do you think the pathology lies? Outer ear, middle ear, or inner ear? Inner ear. Okay, why inner ear? Okay, because the inner ear actually has the sensory receptors both for hearing and for balance or equilibrium. All right, and these two, the first one, which is inside a bony structure called cochlea, all right, this is concerned with the sense of hearing. All right, the other one, which is called the vestibular apparatus, it is concerned with the sense of balance. Now both these sensory organs are composed of hair cells. Okay, these are mechanoreceptors. They detect movement and then they signal to the brain. All right, so we will now go through the hair cells. Okay, we will review some of the basic structures and their basic function, and towards the end we'll try to solve the case study that we just saw. Okay, now basically the ear is divided into three parts: outer, middle, inner. Outer ear collects the sound waves, transmits them to the middle ear. Okay, middle ear acts like an amplifier. You have 3 bones, 2 muscles, right? And these sound waves are then transmitted through the oval window into the inner ear. Inner ear houses the sensory organs both for hearing and for equilibrium. So for the first part of the lecture, we'll focus on the sense of hearing and the organ which is concerned with hearing. Okay? The process of hearing starts from collection of the sound waves by the external ear. All right? Then in the middle ear, these sounds are amplified by the action of ear muscles. Okay? Then the sound waves enter the inner ear through the oval window, and the sound waves enter cochlea. Inside the cochlea, there will be movement of fluid because of the vibration of sound waves. This movement of fluid will then cause vibration of the basilar membrane, okay, which will lead to bending of the hair cells. That will generate the action potential, which will be sent to the brain via the cochlear nerve, to the auditory cortex in the brain. Okay? Now these receptor cells, they are different from other receptor cells because usually depolarization is caused by movement of sodium into the cells. But these cells are present in a fluid which is high in potassium. So in this case, it is the inward current of potassium that leads to depolarization. And the receptors will then send the signal through the cochlear nerve to the brain. Okay? Okay, now if we zoom in at the cochlea. The cochlea basically is a coiled structure, okay, and there are 3 canals inside the cochlea. All right, these are called scala vestibuli, the top one. Scala tympani is the bottom one, and the middle one is called scala media. It's in the middle. Okay, it is inside the scala media, the middle canal, where the organ of Corti is located, which is actually the receptor for hearing. Okay, as you could imagine, the oval window, okay, is linked with the scala vestibuli. The fluid is there, and then the scala tympani opens, not opens actually, it ends at the round window. Okay. If this was a closed structure completely, there was no round window, you will not have the movement of fluid and the vibration of membrane. So you need some place where the energy can escape so that the movement will take place. Okay? So you could imagine whenever the oval window moves in, the round window will move slightly outwards to compensate for the movement of fluid or the vibration. Alright? So every time there is movement of stapes, the foot process of stapes, the oval window will move. This will cause movement of fluid, okay, and this will also lead to compensatory movement at the round window. Now when this movement is happening, okay, the fluid, when fluid moves, it displaces some of these membranes. It causes vibration of these membranes. All right. Now, if you look closely at the structure of the cochlea, okay, so 3 canals, again the same concept. The oval window, scala vestibuli. This is scala tympani. In the middle, scala media. Okay. Outside, which is the scala tympani and scala vestibuli, the fluid which is there is called perilymph, but the fluid which is in the scala media is called endolymph, and this fluid, as I told you, is rich in potassium, so that's why movement of potassium causes depolarization of these receptor cells, as we will see later. Another important thing about the arrangement of basilar membrane in the cochlea is that different parts of the membrane respond to different frequencies. Because sound waves, as you know, the audible range is from 20 Hertz to 20,000 Hertz, right? So different frequencies are there. How our brain appraises different frequencies of sound is by which part of the basilar membrane gets excited the most. Okay? So in the next slide, if you see here, if you look at the basilar membrane from the oval window all the way to the tip of the cochlea, in actuality it is a curved membrane like this here, right? But here, in order to show you in a schematic diagram, it has been straightened out. Okay, so at the base, which is the stapes, the oval window, the basilar membrane is narrow and thick and tight. Okay, by the time you reach the apex, it is now wide, thin and loose. So when the sound waves enter the cochlea and the movement of fluid occurs, okay, for high frequency sounds, the base of the basilar membrane will vibrate, and for low frequency sounds, it will be towards the apex. Okay? Is it clear? All right. Now if we go next, okay, if we look at the basilar membrane more close, because we want to look at the receptor cells. All right. So this is, A is what? Scala vestibuli, C is scala tympani, and B is scala media. Okay. Scala media is where the organ of Corti is located. If you look here now, you will find the hair cells, okay, which are on the basilar membrane. On top of the hair cells, you find stereocilia coming out, and these stereocilia are embedded in a gelatinous membrane. okay, in a gelatinous membrane. This is called tectorial membrane, okay. So if you look more closely, this is the basilar membrane, the hair cell, stereocilia, which are embedded in this gelatinous material called tectorial membrane. Now if you imagine when the sound waves enter the cochlea and causes the movement of fluid, okay, it is like a wave. It will cause movement of the basilar membrane against the movement of tectorial membrane. So basically what will happen, the hair cells will bend in one direction or the other because of the vibration of basilar membrane against the tectorial membrane. So there will be a difference in their movement which will cause bending of the hair cells, the stereocilia, okay. When these stereocilia bend, there are mechanical potassium receptors. They open on bending of stereocilia, allow the potassium to go in. When potassium goes in, it causes calcium to enter the cells, okay. When this calcium enters, it causes the vesicles to release the neurotransmitter. When neurotransmitter is released, okay, it causes stimulation of the nerve fiber and the signal will go to the brain. It's easy, okay. So bending of stereocilia, opening of potassium channels causes depolarization. Depolarization causes opening of calcium channels towards the basal side of the hair cells. Calcium enters in, causes release of the neurotransmitter. Okay, so this is about the hair cells. Now, very interesting point about the hair cells. If you look at the basilar membrane, you will find two populations of hair cells, the inner hair cells and the outer hair cells. The outer hair cells are 3 times numerous than the inner hair cells. So there are about 4,000 inner hair cells in each ear and about 12,000 outer hair cells. Okay? But actually, the sensory cells are the inner hair cells, which are far less than the outer hair cells. So these cells are basically picking up the sound signals and sending signals to the brain as action potentials. What are the outer hair cells doing then? And also another point, 90% of the nerve fibers which are in the cochlear nerve are actually arising from the far less inner hair cells. Only 10% nerve fibers are going from the outer hair cells. Okay? So basically, the function of outer hair cells is not completely understood, but they are thought of as modifiers or amplifiers. Okay? These outer hair cells contain contractile proteins like actin. Okay? And they can actually become longer and shorter. So imagine when you are hearing a sound, okay, there is vibration of the movement of tectorial membrane, which will stimulate the inner hair cell. At the same time, if you change the length of the outer hair cells, it will also cause movement of the tectorial membrane. So you can actually fine-tune the stimulation of inner hair cells. So these outer hair cells also receive efferent nerves from the brain. So they are sensory cells, but they are also motor cells because they can change their length. Okay, so outer hair cells, their main function is to increase the sensitivity of the ear, dampen certain sounds that you don't want to hear, okay, and fine-tune the hearing process. But their function, as I told you, is not completely understood. This is what we know about the outer hair cells. Okay? Are you clear about this concept? How hair cells are stimulated, how they send the signal, the inner hair cells and the outer hair cells? Okay. Now, if there is a damage to the cochlea, if there is damage to the cochlea, but the cochlear nerve is intact, we can implant what is known as a cochlear implant. It is basically a sound receiver, like a microphone. Okay, so you have a microphone over here, the sound processor, which will receive the sounds from the environment. Okay, it will send the sounds to a processor, which is here. This processor has electrodes, about 22 to 24 electrodes, which will be then connected with the cochlear nerve. Okay, so these people can actually hear sounds. All right. As I told you, the basilar membrane, if you remember, different areas of basilar membrane, different frequencies, right? So what this cochlear implant does, the 22 or 24 electrodes, each one of them are detecting different frequencies, and they end in different parts of the cochlea. So high frequency would be towards the base, right? Low frequency towards the apex. So it is like the normal physiological arrangement that is in the basilar membrane. So these electrodes will then stimulate the auditory nerve or the cochlear nerve, and the brain will be able to make sense of the sounds that you're hearing. Okay? Although it is not as good as the natural process, but the patients, after some time, they learn to understand sounds. Okay? Now, the pathways of the sense of hearing, all right, from the cochlear nerve, all right, the nerve fibers go to the cochlear nucleus in the brainstem. Okay, from there they cross over, they go to the superior olivary nucleus, synapse again, then they go all the way to the inferior colliculus, then the medial genicular nucleus and thalamus. From there they go to the auditory cortex. Auditory cortex has two parts, the primary cortex and the association cortex. What do you think would be the function of association auditory cortex? Primary cortex will tell you the sounds, right? Low frequency, high frequency, and you will decipher the sounds that you're hearing. What will be the function of association areas? Interpretation, to make sense of what you're hearing and to associate it with your memory, your past experiences and all that. Okay? And also, hearing is very closely associated with language. Right? In childhood, the development of language depends upon the sense of hearing. If there is a hearing impaired child, he will never learn to speak. So hearing is important for the language process as well. Okay? When you look at the auditory processing, one thing I told you about the basilar membrane, so frequencies can be decoded based on which part of basilar membrane vibrates the most, number one. There's another level to it. If you look deeper, this is known as phase locking. If you know, sound waves are basically compression, decompression waves, right? In the media, if you draw them like this, right? The waves. So there is a compression phase and a decompression phase of the wave. There are certain hair cells for low frequencies, which is from 1 to 3 kilohertz, 1000 to 3000 hertz. In this range, the hair cells respond to different phases of the sound wave. So some hair cells will respond to the compression part of the wave. Certain hair cells will respond to the decompression part of the sound wave. So this is another way by which different frequencies can be decoded by the cochlea. And this is the range, 1000 to 3000. That most of the sounds that we hear, the speech, basically lies within this range. So this range has an extra, you could say, mechanism to differentiate between different sounds very, very clearly. Got it? Okay? Now, sound localization. How do we know where the sound is coming from? One very simple way is we have two ears. If the sound is coming from the right side, it will reach the right ear before the left ear. So from which ear listens to the sound earlier, you can have localization. And you will move your head towards that side, and you will try to look there where the sound is coming from. Okay, so this helps in localization of sounds. And in the brain, again now the association areas, there is communication with the visual areas. So you have, at all times, you have a visual map of the environment. When you hear a sound, then you match it with what you are seeing, so you can immediately focus your attention to the source of the sound. This is for localization. Okay? The third part is that, when you hear sounds, in the auditory cortex, you have a catalog, an archive of sounds there. So you always compare the sound with what you already have there to make sense and to understand. Okay? And as I mentioned earlier, auditory cortex is very, very closely associated with the Wernicke's area that is associated with the development of language. This is in the predominant hemisphere, which in right-handed people will be the left side. Okay? So any questions until now about the sense of hearing? The hair cells, outer cells, inner cells? Okay. Now, let's look at some clinical examples. Deafness. Deafness is inability to hear sounds. Okay? It could be partial, it could be complete, and it could be divided into two types based on the cause of deafness. The first one is called conductive deafness, where the sound waves are not being conducted to the cochlea. The cochlea is fine, but sound is not reaching the cochlea. Conductive deafness. The second one is called neural deafness or sensory neural deafness, in which case the cochlea itself or the auditory nerve itself are not functioning. Okay? And there could also be mixed deafness. Now let's look at some of the common causes for these types of deafness. For conductive deafness, wax in the outer ear is the commonest cause. Foreign body, especially in children, could be a cause. Okay? Presbycusis is hearing loss that occurs with normal aging. This is because of loss of certain neurons in the auditory nerve. So this is a neural type of deafness. Okay? Another example is otitis media. If there is infection in the middle ear, accumulation of fluid, it will not allow the ossicles to move freely. Again, a type of conductive deafness. Okay? Also otosclerosis, where the bones fuse with each other. They no longer move together. They actually become one bone, fused together. Okay? Acoustic neuroma, if there is tumor of the cochlear nerve, this will be neural deafness because the nerve itself is damaged. Okay? Ototoxicity is also due to certain drugs, mainly aminoglycosides. Okay? This damages the cochlear nerve. So this will lead to neural type of deafness. Now, if you have a patient who is complaining of deafness and you want to know whether it is conductive deafness or sensory neural deafness, there are very simple clinical tests that can be performed. One is called Rinne's test, the other is called Weber's test. And these two are performed together to really diagnose what type of deafness is there and which ear, is it unilateral or bilateral. Okay? So if you look at the tests, okay, the Weber's test is very simple. You have a tuning fork, usually 512 Hertz or 256 Hertz. Okay? You strike the tuning fork, so it is producing the sound. Now, one thing you have to tell the patient before you do this exam, that you're not asking about the vibratory sense. Have you done the vibratory sense in the clinical skills, right? There you ask the patient for the vibration, right? Here you will ask about the sound. Where are you hearing the sound best? For Weber test, you put the tuning fork in the midline, either on the forehead or on the vertex, the base of the tuning fork. The sound will conduct through the bone and reach the inner ear. And the patient will be able to hear the sound. Okay? If there is sensory neural deafness, for example, on the right side, the patient will say, I'm hearing best on the left side. Okay? If there is conductive deafness on the left side, would it make any difference in the Weber's test? Okay, theoretically it should not, but it does practically. Because when there is blockage of the ear, okay, conductive deafness, the sensory part of that ear becomes more sensitive. So the patient hears better on that side where there is conductive block. The sensory part is okay, there's conductive deafness. So the patient would say that I'm hearing better on this side. The reason for this is not completely understood, but there are some theories that, the ear which is open, the conductive pathway is open, there is some sounds coming from outside, so there is some dampening of the sound that you're hearing from the turning fork. But mainly, Weber's test will recognize sensory neural deafness if you don't hear properly on one side. Okay, so this is basically comparing the two sides. In case of Rinne's test, you are comparing air conduction against the bone conduction. Now, air conduction is always better than the bone conduction. Alright? So, normal Rinne's test result will be air conduction better than the bone conduction. There are two ways to do this. The first one is you ask the patient, first you put the tuning fork on the mastoid process, this is bony conduction. Then you put the fork out just outside the external auditory meatus, this is the air conduction. Okay? So you ask which place you are hearing the sound more. This is one way. The other way is you ask the patient when he stops hearing the sound. So for the bone conduction, it should be shorter because the sensitivity is less. For air conduction, it should be longer, usually double the time of bone conduction. So normal Rinne's result will be air conduction better than bone conduction. So you do both sides. In order to diagnose a patient, whether he's suffering from bone conduction or air conduction loss or mixed, you have to do both these tests. And when you put the result of both these tests in a table, you will be able to diagnose different types of deafness. Okay? If I show you in the next table. Now, normally, I told you the Rinne's test for both ears should be air conduction better than bone conduction, right? For Weber's, it should be no lateralization. So patient should say, I'm hearing on both sides equally well. So this is the normal result for a normal person. But if the Rinne is normal, Rinne is okay, but the patient tells you that the Weber lateralizes to the left, it could be either sensory neural loss on the other side, because he's unable to hear there very well, okay? Or it could be, this is just a sensory neural loss, okay? If it lateralizes to the opposite side, sensory neural loss. All right. If you go to the next step now, if for Rinne's test, for example, on the left side, the bone conduction is better than the air conduction. What does it tell you? Just look at the Rinne's test first. On the left side, bone conduction is better than the air conduction. Sorry? Conductive deafness, right? Conductive deafness, because the outer ear and middle ear is not conducting the sound waves the way they should. Okay? Now you look at the Weber's test. If the Weber lateralizes left, so it confirms what you did with the Rinne's test. Conductive deafness in the left ear. Okay? But if the Weber lateralizes to the right, it could be a mixed disorder. There could be conductive deafness, okay, and sensory neural loss on the left side. So it could be a mixed type of deafness. So you can now differentiate between the two. Same thing on the, if the right ear, bone conduction is more than air conduction, so it will be, and the Weber's test, so you can know which side, which type of deafness. Is it pure conductive? Is it pure sensory neural, or is it mixed? Okay. The third possibility, if the Rinne in both ears is bone conduction better than the air conduction. Okay? And the Weber does not lateralize, it means conductive deafness in both ears. For example, otosclerosis on both sides, or middle ear infection on both sides. Okay? But if Weber lateralizes, If Weber lateralized is left, it means there is combined loss in right, and there could be conductive loss in the left. So there is sensorineural part as well now. Weber can add that information. So by doing both these tests, Rinne's test and Weber's test, and putting the results in a table like this, you can be sure about the type of deafness on both sides. Okay? So just go through it again, try to make sense, and if you don't understand, you can always ask me again. Okay? Now, another test which is used nowadays is called audiometry. Okay, so the patient sits in a quiet room with the headphones on. Different tones and different frequencies of sounds are produced in the headphone, and whenever patient hears the sound, he presses or she presses the button. So you have a full map now, starting from 20 Hertz to 20,000 Hertz, different loudness, a full map, which area or which part the patient could not hear. So you can have a very complete audiometry map to tell you what type of sensory loss is there. Okay? Any questions about the sense of hearing and the hearing tests? Does it mean you understand everything? Okay, that's good, that's good. All right. Let me ask a question then. Okay, what is this child trying to do? Sorry? Why? And how? Sorry? Opening the eustachian tube, right? If the eustachian tube gets blocked, because the middle ear, the pressure in the middle ear should be regulated very well to allow for ossicles to move properly, right? So that's why there is a link with the outside environment through the eustachian tube that opens in the pharynx. So pressure is always like the atmospheric pressure. But if the eustachian tube gets blocked, the pressure in the middle ear may increase, which happens when you are traveling by air, when the aeroplane ascends, right? Okay? And actually, you know, the small children, usually for us, what we say, keep swallowing or eat chewing gum, right? So that when you swallow, your eustachian tube actually opens and allows the pressure to equalize. For children, okay, there is a natural response that actually helps them, you know, save damage to the tympanic membrane, because the pressure becomes too high, tympanic membrane may rupture, right? So infants, what they do? They cry. So crying opens the eustachian tube and the pressure becomes. So if the child is crying when the aeroplane is taking off, let him cry. Okay? Alright, now after the sense of hearing, let's talk about the sense of balance or equilibrium. Okay? Now the sense of equilibrium or sense of balance is from different receptors. It's not only the ears. Okay? The information the brain gets is from the touch receptors on the skin, the proprioception, the movement of joints, etc. Okay? Vision, because we see the environment, so brain also gets information from the eyes about the environment. And then the vestibular system in the inner ear. Information from all these different receptors will allow us to maintain our posture according to the gravity and, you know, different movements that we perform. All right? Today, our focus is mainly on the vestibular system. So we're not looking at the others. The vestibular system, okay? Now, we saw this part just now. This is the cochlea, all right? Inside the cochlea, we saw the 3 canals, right? And the hair cells, okay? In addition to cochlea, the other sensory organ is the, we call it the bony labyrinth, because it's like a labyrinth. Inside the bony labyrinth, there is membranous labyrinth. And this membranous labyrinth has different parts, okay? The base of the labyrinth is called utricle and saccule, which is here, okay? Utricle is this part, this one, all right? And saccule is this part. Utricle is more horizontal, saccule is more vertical, okay? In addition to these two, then we have 3 canals. We call them semicircular canals. These semicircular canals are again filled with fluid, the endolymph. At the base of the semicircular canals, there are the sensory receptors. Now, sensory receptors here are of two types. One type is present in the utricle and the saccule. This is called maculae or macula for single. Okay? And the receptors which are present at the base of the semicircular canals, they are called cristae ampullaris. So two types of receptors, although their functioning is quite similar, okay, but there is some difference in their structure and how they sense the movement of head. Okay, so utricle and saccule, the sensory organ is maculae. Okay, semicircular canals, the sensory organ is crista ampullaris. Okay, let's look at the utricle and saccule first. The maculae are also called otolithic organs. What lith means? Lithic. Stones, right? Renal stones. What do you call them? Nephrolithiases, right? So basically in the ear there are these stones. They're not very big, so we call them sand. So there is sand in the ear, in the inner ear. Okay? These sand particles, sand-like particles, they are heavy. So they help in moving the hair cells of the receptors, as I will show you later. Okay? So one of maculae is in utricle, the other one is in saccule. Okay? They are surmounted by what is known as otolithic membrane, again a gel-like membrane on top of these cells. And on top of the gel-like structure, you have these sand particles or otoliths. Okay, if you look at the picture now, okay, so these are the hair cells. This is the nerve. The hair cells have these stereocilia. On one side, you have the long one, which is called kinocilium. Then you have gradually shortening stereocilia. They are embedded in this gel-like material on top, this blue color one, gelatinous material. On top of these, you have these small stones or sand particles, which are on top. Now, these sand particles are very heavy, right? So imagine now if there is any movement of the head or tilt of the head, these sand particles, because they are heavy, they will fall on that side, right? When they fall, the gelatinous material will also move with them. When it moves, it causes bending of the stereocilia. Again, bending of stereocilia will open the potassium channels. Potassium goes in, depolarization, and action potential is generated. Okay? Now, important thing to note here is, as was with the auditory hair cell as well, that bending of stereocilia towards the kinocilium opens the potassium channels. Bending of stereocilia away from the kinocilium closes the potassium channel. So it can detect both ways. One way it will depolarize, other way it will hyperpolarize. Okay? And these stereocilia are joined with filamentous attachments. They are so small, they are even difficult to see under electron microscope. But these stereocilia are joined together. Okay? Are you clear about this? Now what happens that these stereocilia are present in the inner ear. Okay, so this is the otolith or the Statoconia on top. If you move your head because of gravity, because the Statoconia are heavy in weight, they will fall. For example, if you move your head backwards, they will fall backwards. In this case, the stereocilia move towards the kinocilium, depolarization, and increased impulses will be sent to the brain. Basically, the hair cells, when your head is upright, are sending a baseline stimulus to brain all the time, about 100 per minute. So when you bend forward, this 100 will become less. When you bend backwards, this will become more. Now the hair cells are located in all 360 degree of the plane. So movement of head like this way, every way you move your head, some of the stereocilia will bend this way or the other, and the brain has a full map of these stereocilia, so brain will know which way the head is bending or moving. You got this point? So even with your eyes closed, you know which way the head is bending. Okay. The semicircular canals are 3 in number. Why 3? Because we live in a 3D world and we want to know the movement in all different planes, X plane, Y plane, Z plane, right? So 3 canals are located in all these 3 different planes. Okay? These are called superior, also called anterior, to confuse you further. Okay? Posterior is only posterior. Horizontal is also called lateral. Okay? And at the end of the base part of the semicircular canals, you have the receptor called crista ambulantis. Okay? If you look closely at this receptor, this is at the base of the semicircular canal. Okay? You have this gel-like material on top. This is a cone-shaped material. Okay, it's called cupula. All right. We love to have these fancy names, right? And then you have these hair cells. This is the chylocilium. So movement of cupula in one direction will cause depolarization. Other direction will cause hyperpolarization. Now what happens when you move your head? Okay, the bony part of the semicircular canals moves with the head, but the fluid inside will lag behind, right? Because of change in inertia. So the fluid will actually lag behind. This lagging behind of the fluid will cause bending of the cupula. This bending of cupula will cause movement of the stereocilia and the signal will be generated. Now one thing which is important to note here is the difference between these and the crista, the maculae. The maculae, whenever you move your head, because of the movement of the Statoconia or the sand particles, there will be some movement of the stereocilia. In case of semicircular canals, I told you when you move your head, the bony part of the semicircular canal moves with the head, but the fluid lags behind. But if you keep spinning for some time, the fluid will catch up. Now the fluid is moving with the same speed as the bone is moving. Now there is no bending of the cupula anymore. So semicircular canals only detect a change in rotation of the head when you are moving in a particular rotational movement continuously. The semicircular canals cannot detect that. They stop firing. But when you stop, again what will happen? The bone comes to stop, but the fluid keeps moving for some time. So it will detect when you start the movement, when you stop the movement, or during the movement if you change the speed. If it is constant speed, the semicircular canals will be unable to detect. You got this point? Okay. Now, so I already explained to you the 3 semicircular canals. Now, if you all want to know which canal is in which direction, you have to do this with me. Say yes. This is the superior or the anterior semicircular canal. Now say no. This is the posterior semicircular canal. Okay? Now touch your head with the shoulder on both sides. This is lateral semicircular canal. Okay, so these different planes are detected by different semicircular canals. Okay, easy to remember? Alright. Now, let's look at the sense of balance on its own. There are different types of equilibrium that we can detect. One is called static equilibrium. Okay, static equilibrium, which is simple, detected by the maculae. You move your head forward, backward, you lying down. This will be detected by the utricles, because when the sand particles fall on one side, it will cause the stimulation of hair cells. Okay? The other one is called linear acceleration. So suddenly, if you are sitting in a sports car, what you will do, you just press the accelerator with full force, right? And the car will go very fast. What happens then? You feel like you're falling backwards, and suddenly as a response, you try to bend forward in order to avoid falling backwards. This is linear acceleration, again detected by the utricles and saccule, okay? Because this is linear. For semicircular canals, it has to be rotation that they will detect. It has to be rotation. Okay, so when there is rotation of the head, semicircular canals will detect, and as I told you earlier, okay, when you begin rotation, they will fire, but when you keep rotating, their firing level will drop to 0. You are rotating, but they are not sending any signal. But when you stop rotating, again, they will send the signal, but now the opposite one, right? If you are recording from the same semicircular canal. So semicircular canals detect rotation, the start, the end, and any change in rotation. Now, another function of semicircular canals which is very interesting is known as the predictive function. Okay, for example, you are running, okay, you are running, and there is a curve that you have to turn. You have to turn, okay? The semicircular canals are sending a constant signal to your brain about any change in the velocity when you are running. And if you are turning, again this turn detected by the semicircular canals and the brain would know. Okay? So what the brain does, that it makes a predictive, you know, on the way you are turning, if the brain already plans that how much force different muscles in your legs, the left leg and the right leg, the flexor, extensors, should be given in order that you turn very nicely without overshooting or undershooting the turn. So semicircular canals, by providing the brain a constant information about the change in the velocity when you are moving, can allow the brain to predict and to plan the next movement very carefully so that your movements are very smooth. This is another function of semicircular canals. Okay? Okay, now the vestibular pathway, now the nerves which are going from the utricle, saccule and the semicircular canals, they end up in the brainstem, and there they have a lot of connections. Why a lot of connections? Because I told you earlier, equilibrium is not the function of just the semicircular canals or the inner ear. It's the function of many other senses. Okay, so if you look here, there is a lot of fibers going to the cerebellum. Why cerebellum? What is the function of cerebellum? Have you done cerebellum? Right, maintenance of posture, balance, fine movement. So you get a constant input from the head, and the cerebellum can then plan the movement in a more efficient and more in a better way. Okay, the fibers also pass downwards to the muscles directly without going to higher centers. So you can also control the anti-gravity muscles in order to maintain the balance. Okay? And fibers also go to the red nucleus and then go upwards to the higher centers, and they also have different roles. Okay? There are also fibers that will go to the extraocular muscles, the muscles that control the movements of the eye. Why would you think so? Okay, while looking at me, suddenly turn your head but keep looking at me, right? So your eye, actually when you move your head to this side, the eye moves the opposite side if you want to keep your gaze on a certain thing, right? Okay, so whenever you're moving your head, you need to move your eyes in the opposite direction if you want to maintain where you're looking at, the gaze, okay? So this also is important, because with the head movements, you will have fine movement of the eyes so that you don't lose the gaze where you're looking at, okay? All right? Okay, now there are different types of dysfunction which are associated with the vestibular system. The most common one is vertigo, feeling of dizziness, okay? Vestibular neuritis, Meniere's disease, acoustic neuroma can also cause problems. Ototoxicity with drugs can impair hearing but also impair the sense of balance, okay? Sometimes those people who have severe migraine, they can also have vertigo. Right? The actual mechanism is not completely understood. Certain autoimmune diseases can also lead to destruction of these cells and would lead to impairment of balance. Okay? There are certain tests which can be done. Right? The first category is known as the rotation tests. Okay, so these tests should be performed with caution because they will make the patient dizzy at the end. So, you know, if you are performing these tests, there shouldn't be any sharp objects around there, or the patient will fall over. Okay, so you have to perform them carefully. There are certain tests like EEG. You can measure the potentials, you know, the electrical activity of these receptors, but they are very sophisticated tests, not usually done, only in special cases. Okay, now if we come back to the case that I presented to you in the beginning, what do you think? What is the problem now? So the problem actually is both in hearing and in balance. So this is a problem which is affecting both the cochlea and the vestibular apparatus. Okay, this actually is an example of Meniere's disease. Okay, Meniere's disease is a mysterious disease. The actual cause is not known. But what happens is that there is too much production of endolymph. So there is high pressure of endolymph, which destroys the hair cells. Okay, so basically is linked to endolymphatic hydrops and excess of fluid in the middle ear. There is swelling of the membranous labyrinth, the semicircular canals, and so the endolymph leaks from its normal channels in the ear and flows into other areas, causing damage. Okay? All right, now common disorders of the vestibular system are usually rare. Cochlear system is more common, the clinical diseases. Okay? Now, if there are any questions, please ask me now, or we go for this. Okay, this is a Padlet wall where you can post questions if you have any, and I will reply to your questions, so everybody can benefit from our question answer session. Okay, and we all are ready. We play a short game. Okay, thank you very much.